I'm Sarah Hawley. I'm the faculty lead for the Education and Training Work Group within IHPI. And I want to welcome you all to today's seminar. We're really excited to be having a special panel focusing on health policy forecasts, which is going to be moderated by Dr. Renu Tipernini. And I'm going to pass it over to her to introduce our panel. I think probably many of you know Renu as an assistant professor in our division of general medicine here and a member of IHPI doing great work in the Medicaid expansion area and policy impact and has received awards for her work in this space. And we're extremely excited, Renu, to have you moderating today. I'll keep an eye on the chat as well, but please, everyone, feel free to type questions in, but I think it's going to be, there'll be lots of opportunities for discussion. Renu, please.
Thank you, Sarah. And I just wanted to say I'm here as a representative of our IHPI policy engagement team. Really thrilled to have our two speakers today. I feel so fortunate that we can share this dialogue. So let me introduce our esteemed speakers. First, we have Hemi Tewarson, who's the Executive Director of the National Academy for State Health Policy. I think many of those of us interested in state health policy know NASHP to be a leader in this space and really pushing the envelope on lessons learned across states. Hemi has been at a variety of organizations leading health policy initiatives even prior to her taking the leadership role at NASHP. Some of these organizations include the Duke Margolis Center for Health Policy, the National Governors Association, and she's really overseen a large portfolio of work in health policy, including this important focus on state health policy. We also have another esteemed speaker, Dianne Hasselman, who's currently the Interim Executive Director of the National Association of Medicaid Directors. She first joined NAMD as a Deputy Executive Director in February 2017 and has been a leader since that time. She manages a broad spectrum of activities there, including focusing on public policy and advocacy agendas in coordination with the Board of Directors, overseeing grant-funded programs and developing new initiatives. Both Hemi and Dianne are really national leaders in health policy and really do a lot of important work in state health policy. So I'm thrilled that we get to host them here at IHPI. And so to kick us off, we're going to have both Hemi and Dianne introduce themselves a little bit. So I'm wondering if each of you can talk a little bit about yourselves and your organizations. So tell us about your background, a little bit more about your members, and what kind of policy work does your organization engage in? And Hemi, do you want to start us off?
Sure. I was just waiting to see who you wanted to go first. Well, first of all, thank you for having me. It's a pleasure to be here today. And I hope we can have a true conversation. I feel like I learn every time I present, so I really do want to make sure I hear from all of you as well. So just in terms of my own background, I am a state health policy wonk, and I have been for a long time. But I did start out in the private sector, really working with health systems and health plans and helping states from the sort of corporate side of really how does the healthcare system work? And I have to say that was not my true mission. So I moved on from that private sector work and I went to the federal government, where I worked with the U.S. Government Accountability Office, really their senior attorney advising their really 200-person healthcare team and really identifying what issues we should really focus on for Congress. And that was very interesting work, really, I think, impactful until the Affordable Care Act happened, when the GAO really kind of moved to a lot more of oversight and really, I'll just be very honest, partisan arguments over whether the AC was good or bad thing. So I realized at that point, I have to go and work with the states because that is really where policy is moving on healthcare. And so I joined the National Governors Association, where I eventually led the healthcare team. And now, of course, I'm here at NASHP. And I did do a stint at Duke Margolis, so I very much appreciate sort of an academic perspective of the work and how that can be a different language, although really impactful as well. And here at NASHP, for those of you not familiar, we're a nonprofit that's been around for 35 years. We really are a trusted partner for states. And I think what makes us distinct from other sort of state-based organizations is we're not a membership organization. We really, state leaders sign up to be part of our academy, which we have 64 state leaders as part of our academy, and they advise our work through different committees. as well as we have tons of working groups, but they voluntarily want to be a part of NASHP, not because they want to, pay dues and be part of their peer group, which I think is really, really important work, and Diane's going to talk about that, but because they want to really find out kind of what are new ideas on policy. And so two things I would just share, I think, in reflecting kind of NASHP and what we do. One is that the work is very cross-sector. So the type of state leaders we work with are legislators, governor's offices, Medicaid directors, public health officials, social services officials, health and human services secretaries, state-based marketplaces where we're actually their pseudo association. So it really, insurance commissioners, it brings, I think, lots of opportunity, but I will say challenging as well to really talk to those different audiences and engage them in cross-sector work. The other thing I will say is, and this is just my reflection on being at NGA and now being here at NASHP, NASHP, we really, we want to surface what are best practices in states, how can states learn from one another. It's really important in moving policy forward. But there's also sometimes like, what is the next step? And it's unclear. And so in some of our areas, this is not true in all the areas that we work, we really try to identify by talking to other experts, academics, even the healthcare sector itself, what should we be doing next? And then, we do things like draft model legislation, do legal analyses, think about, thought papers of, where states can go next. And I feel like that was the kind of work I really couldn't do at NGA because we were a membership organization and we had to be respectful of our members. So I think that gives us, I think, a little bit more leeway of truly being a think tank and being able to suggest ideas. And let's be clear, like not every policy idea works, but I am a true believer that you have to keep trying when the system is not working as it should. So I can stop there, and we can talk more about sort of topic areas as we get into the discussion.
That sounds wonderful. Thank you so much, Hemi. And it's also interesting to have you draw this distinction between membership and non-membership organizations and different approaches to impacting policy. I didn't realize you had started out in the private sector, so I'm sure that informs a lot of your cross-sector, stakeholder engagement. And, Dianne, I would love to invite you to introduce more about your work and NAMD, because when we think about state policy, Medicaid is always one of the top things we're thinking about, and the leadership that you're taking there. Would love to hear more about your background and, of course, of NAMD.
Sure, absolutely. And Hemi set it up well because we are a membership organization, so we do have a very different perspective. So that's super helpful. But first of all, so my background, I have a master's in public health. I got it from UNC Chapel Hill many moons ago. I went right into consulting for several years with a large consulting firm and did that in the Medicaid space, and then made my way to the nonprofit world. And I've been at the National Association of Medicaid Directors now for 7-8 years, something like that. So I absolutely love the kind of being of service to our members. I deeply respect our members. They are public servants. Medicaid directors are. And so it's just been a really lovely fit for me, just personally. As the deputy director, I'm more about kind of operating the organization, making sure our members are getting what they need, that our programming is right, our team is right. So less the deep dive into the nuts and bolts of Medicaid policy and operations, which can be excruciating. But so more about running the association. Again, we are a member association. We've been around for 10 years. As a member association, we represent every single Medicaid director. So there are 56, one in every state. We have one in DC, and then the territories as well. So that comes up to 56 individuals. They are either appointed by a governor, or they grow up within the state Medicaid agency. Sometimes they are hired in externally from the private sector, although that's not so common. So they really represent a wide range of expertise and background. Our 56 states and territories are all very different. They have very different cultures, very different demographics, very different politics. different size of their programs, their budgets, how much they include in their Medicaid program, what they how much or how little they include in their Medicaid program. So very different, and that is the challenge again that Hemi referred to, is finding that sweet spot. Where does everybody agree, align, and surprisingly, they do in the vast majority of the time. We are a nonprofit. We are bipartisan. Again, we do not pick a side. We elevate what the states are going through in their perspective. We are small. We're just 10 people, so we're a small association. And we're, just in case it's of interest, we're funded by grants, by member dues, and then also by, we have 2 big meetings a year, and one brings in a lot of sponsorship and funding that way. So our total annual budget is only about $4 million. So we are a tiny little association. So hopefully that gives you a little bit of a background of me, and then also of who we are at NAMD.
Thank you so much, Diane. You know, it's wonderful to hear about your rich experience and background in your career. And also, I had no idea there were just 10 people at NAMD, because, you know, all the work you do, the scope is so large. And so, you know, that kind of segues into the next set of questions I have for you and Hemi, and maybe you can start us off first this time, since you're on a roll. You know, at our institute at IHPI, we talk a lot about how policy is made through various paths, you know, for example, through legislation, appropriations, agency work, regulations, executive orders, judicial decisions.
Sometimes they are executive
decisions. I know, maybe a Freudian slip there. So I wonder what you all think about, you know, where do your organizations and your members focus most of your energies in policymaking, and how do those activities impact policymaking? I think that could be really helpful to educate us here.
Yeah, so I guess I will elevate two different areas, and from our members kind of impact the federal level. So here in DC, where we're based, so either Congress or the administration, Centers for Medicare and Medicaid Services, or CMS. That is part of our job at NAMD, is to identify what are the common policy pain points, or the challenges that states have operating their programs, and we elevate that up to the federal government here in DC. And Medicaid is a federal state jointly paid for program. So so that's that we really kind of try to carry the water at that level. Individual states meet regularly with their federal partners at CMS to talk through the nuts and bolts of their individual state Medicaid programs, the waivers they want to implement, the state plan amendments, just basically how they want to operationalize their program. So they'll have those one-on-one conversations. But the other master, of course, for state Medicaid programs is their state legislature. And the Medicaid director develops their budget. They've kind of just gotten through that process, developing their budget for the year with their governor. They will be bringing that to the state legislature starting in January. And the legislative session goes through the request for Medicaid. There are a lot of questions from the state legislature. So the Medicaid director spends an inordinate amount of time explaining Medicaid. It's not Medicare. Here's what we do. That's that sort of a thing, to defending why are we asking for this money? Who are we covering? Why? What do we give as a state in terms of coverage? And so that is a process that will be happening in the new year. And so those are kind of the different big buckets, if you will, of their energy around policy making.
Thank you so much, Diane. I think that highlights the true federal-state partnership of Medicaid and the, the influence of NAMD at the federal level, and then of, state Medicaid directors, the members. I'm just thinking, I was having a flashback to where I've been an observer at some of those hearings of the Medicaid directors here, talking to the legislature, and how it seemed very stressful to me, but how cool, and collected they are in describing what their proposal is with the governor. So now, a different take on this, Hemi, I would love to turn to you to get a sense of how NASHP approaches this in terms of, how does the organization think about focusing energies related to policymaking, and how do those influence policymaking?
Yeah. So I would say, Diane, I agree with all of the things that she said in terms of the Medicaid program and what NAMD is so good at. I would say here in NASHP, we work on a lot of different areas in healthcare. So I might just focus on one just as an example to help sort of just shine a light on how we sort of work with states and their authorities they need. So affordability, it's a big priority for us here at NASHP. And there's affordability in a lot of different ways. And it's across payers. It's not, it's not just about Medicaid costs. It's about the commercial market. It's about people who are uninsured, et cetera. And through that work, there's sort of different perspectives that we have to think about. One is, okay, how do we address rising drug costs and rising health system costs, just as an example. And when we work, hand in hand with state leaders, it's really finding where are those champions. And I really think all of like the really big policy ideas behind it is a really strong leader, whether it's coming from the insurance commissioner or the governor's office or the Medicaid director, or legislator. There has to be those champions on the state side in order to really carry through on a big initiative. So in a tough area like affordability, where a lot of people are coming at you saying, don't do that, status quo, we really have to work hand in hand to develop, okay, what are model laws? What are the legal analyses that we need to think about to really anticipate what those legal challenges are going to be, the stakeholders that are come out, and you've talked to all the other congressional folks about why this is a bad idea. How do we build coalitions with consumers and employer groups to get things done? And so that's just like sort of one realm, is like on the legislative side. I think there's also governor's executive orders. Sometimes a lot of governors, based on my work at NGA, they're not necessarily healthcare experts. A few are, but that's really the minority. And so, but some of these big initiatives, you need to have that kind of leadership to really withstand the challenges that come at you for these really hard policy changes that you want to make. So, which includes like, Medicaid expansion too, right? You need that gubernatorial support. So in some of those projects, we've said, okay, we need to bring the governor's office on board, and it's an executive order is going to help. It's going to set the tone for what work can follow and how we can really get it done. So I think that's a piece. The other thing I would just say is some of these initiatives, like when we talk about social determinants of health, you really have to think about it cross-sector. And it's really hard to do cross-sector work in state government because our entire system has been designed to have different funding authorities and requirements and, all of the different ways it's operationalized. So to push people together and say, okay, go work together and go solve this, it's really a lot of work that has to be done. And so things like executive order and creating, a committee or a cabinet, or all of these different sort of pieces on the executive branch side is also really important to really get some of that work done. So there's a couple of examples for you.
Thank you so much for sharing those rich examples, including it's really interesting to hear you highlight the importance of executive orders as setting the tone in leadership, which is really interesting to think about. And then the different stakeholders, even within state government, as you said, it seems like everybody should be playing together, but there are these huge agency, silos. And so thinking about how to set that collaboration is really important. As we segue to the next section, I wanted to tell people, feel free to post questions in the chat that I will monitor along with Sarah and weave in. Because we'll be shifting to talking more broadly, and then also to get, Diane and Hemi's take on forecasting to the future as well. So, talking now, let's talk a little bit about key state and federal priorities that your organizations and the states focus on. So, for example, how do they come about those priority areas, and give us a little idea of what's going on now too. And either Hemi or Dianne, whoever wants to jump in first.
All right, Diane's giving me the nod, so I will start, and I'll go broad. So I've been executive director here at NASHP for about a year and a half, and I said I can't do this job without a strategic plan on what policies we need to focus on, because there's so much we can do in health. So the way we set our work with states is, what do they need? What is most pressing to them? And, our academy has lots of different types of state leaders that I described. So coming from different perspectives, what is keeping them up at night? Where do they need help? And how can NASHP fit into that? And so I'll just list, and I'll try to keep it short, but there are, I think, a lot of really pressing priorities. And I was just in my board meeting today, and they're like, "Hey, you're really going to work on all of that?" I'm like, "Yes, we are, because we have to. There's just so much to be done, and the state leaders really are asking for this help." So workforce, I just wanted to just highlight this for you, because I'm going to talk about it later in terms of where academic institutions can help us. Workforce, when I was at NGA, was like the third tier. Like, the governor's office was like, "Yeah, go talk to the workforce people. You want to do a workforce project? Okay." But with the pandemic, it really has risen in terms of priority areas, because of the crisis within hospitals, and also just the need that has really been exacerbated, on the long-term care side and the behavioral health space, and really trying to connect with community. So I think that is a really emerging area that we really need to focus on. And I would say, from my perspective, we're doing work on midwives and doulas and community health workers, sort of alternate peers for addiction, these alternative types of workers, the direct care workforce for the aging population, and, direct care for, support for nursing and primary care. But I think, from a state perspective, we need to think about supporting states to think more holistically about the workforce they need now, 5 years from now, 10 years from now, and how to make those investments in sort of the most effective way. Equity is, I think, the COVID pandemic has really, we all knew, right, who work in this space. We have huge disparities in this country. They've been exacerbated. They've been there's been shown a bright light on this, and shame on us, right? So there's so much I think we have to catch up on in terms of work and how to approach it in different states. It varies, right? How you can talk about it. You can't talk about ending structural racism in some states. You have to address it as reflecting community and addressing disparities. Social determinants of health. We here at NASHP are particularly focusing on housing, although I think there's others that are just as worthy to focus on, because of the link to better health and really helping states. It's really hard to think about housing and health and working all of that together. Behavioral health is a big area of need, which I already talked about, both on the children and adult side, and with the substance use disorder, which I think had a lot of attention years ago. When I was at NGA, we could not do a governor's meeting without doing an opioid session. But then we kind of faded away from that. And we're at a crisis now again, right? The overdose rates are very high, and you have lots of settlement money flowing. And boy, I hope we're going to make a difference with all those dollars, $50 billion available at state and local levels. Aging, it's a particular topic that's near and dear to my heart, because I feel like I've been, really thinking about this for a long time in terms of getting state leadership to focus on it, not just, the Medicaid folks that work on home and community-based services and the aging directors that focus on aging, but really across leadership at state levels. And I'll say the direct care workforce I already talked about. There's also the future of nursing homes. Where are we going with nursing homes? Are we going to, the census is lower in some states. Do we repurpose them? How do we continue to pay them? Venture capital is coming in to really take over some nursing homes. Is that going to be a good outcome? I fear not. So kind of what are the next steps? And then the last thing I'll just say, and then I really do want to turn over to Diane, is the future of public health. So, we are, I think, at a decision point for public health. There are some states that are saying, look what happened in the pandemic. We need to make it better. There's federal dollars flowing. We're going to improve our data systems and do all these things. In other states, it's like, well, they didn't make the right decisions. We're going to pull back authorities. We need to do things in a different way. And I think the traditional public health folks are really thinking about, how do we talk about public health differently, and how do we really get some traction? And, our work here at NASHP is about, how do we better connect public health to the healthcare system? Because it has to be sort of a more integrated approach without making public health feel like they're going to get lost, which is, I think, the biggest fear. So I'll stop there because I'm sure Diane has lots of good things to talk about too.
Yeah, I mean, Hemi, so many of the things that you've lifted up our Medicaid is at kind of the tip of the spear of those behavioral health, LTSS, the direct service workforce, simply because Medicaid is the largest, pays the largest amount for those services. But covering a couple of other topics. So top of mind is certainly unwinding from the PHE. And I don't know how many of you have heard this term, or if it's just something here in DC, folks are talking about, but essentially what happened is Medicaid agencies were told when the pandemic hit, you can't do redeterminations of Medicaid eligibility. If people are on Medicaid from January 1, 2020, they stay on until the end of the PHE. And we're still in the PHE, right? It's 3 years in and we're still there. So what's been happening is the Medicaid rolls have been increasing all these many months. And they are up to, I think, north of 90 million at this point. And I think before the pandemic, they were more around maybe 78, 80, something like that, kind of depending on what your source was. And so when the PHE is lifted and Secretary Becerra has that authority to do that, Medicaid agencies will have to do redetermination of eligibility for every single individual. So for 90 plus million people on Medicaid, the states will have to go through that eligibility redetermination process. There are a whole lot of operational issues related to that, as you might imagine, but that is a major priority, the dominant priority right now for Medicaid agencies. So that's one part of unwinding. The other part of unwinding, again, when the PHE is done, is all of the other flexibilities that were brought on board very quickly back in, around March 2020. So whether it was a lot of the telehealth flexibilities or giving providers greater administrative flexibility, for example, those were two good examples where it's going to be really hard to kind of walk those things back. People have gotten really used to telehealth, and maybe even more so providers have gotten really used to telehealth. So how do we find the services, the telehealth, for example, that is the same or higher quality at the same or lower cost for taxpayers and for Medicaid programs? So that would be a great area of research and evaluation. The other policy issue to elevate is not just workforce, but state agency workforce. And the state Medicaid agencies, like public health, have just been decimated. There is such low trust in public service and public agencies. States have always been challenged with their workforce, but this is really unprecedented. We have some states that are, some Medicaid agencies that are facing 20, 30, even 40% vacancy rates. If you think about trying to do work in your organization with 40% of the spaces open, oh my God, so that's a real challenge for the Medicaid directors, is keeping them, they have a very demoralized workforce, that sort of thing. So anyway, those are some of the other things that COVID really elevated for Medicaid agencies.
Thank you both so much. I mean, the issues you both have elevated are so pressing, and it kind of was interesting for me to reflect how we started and ended with a discussion of workforce in different spheres. And I really appreciate that as a healthcare worker myself, that conversation started there. I was kind of surprised, actually, Hemi, that you brought that up first. And then Dianne, thinking about tying, all kind of public service, workforce, not just public health, but really agencies. So important. I'm thinking about our colleagues in our state Medicaid agency and how much turnover there has been just in these last 2 years. And I had a follow-up question from the audience that I'm going to direct first at Dianne, but I think both of you could weigh in. since you mentioned the public health emergency unwinding, currently set to, unwind after January, but we'll see if that gets extended or not. One question from the audience is, what do you identify as major advances in health policy as a result of the public health emergency? And in what ways are states preparing for that PHE unwind?
Oh gosh, well, the first one is, I think there are many ways that are silver linings, if you will, and telehealth clearly is huge. I think a second one is state governments can move quickly. They can actually move really fast to see what Medicaid agencies did at the beginning of the pandemic to ensure access, to provide coverage. Very impressive. I think the other really neat thing, and this is not, this is happening everywhere in many workplaces, and that is just a real flexibility for state agency workforces. And I think this is one thing that is very helpful as states try to address their workforce shortage within the Medicaid agency, and that is a greater flexibility for digital work, so telework, and that has even freed up some state Medicaid agencies to sell off real estate to free themselves of huge, formerly they were the building that housed, the state building that housed the huge Medicaid agency or other agencies, and they've just sold off that real estate because they can no longer fill it because people are working digitally and don't need any reason to come into an office downtown. That's not in every state. Again, states have different perspectives on that, but I guess those would be three things I would elevate as true silver linings. I think in terms of planning for the PHE, oh my gosh, states have done nothing but plan for the end of the PHE for the last year and a half. We have every other week we are having all state calls with CMS to go through plans, whether they're related to the redeterminations or communications with members. That's a huge thing. States have been doing a lot of work on their eligibility systems and on developing dashboards so that they can track when it's go time, they can see how they're doing and how they're progressing. So just a ton of work. The challenge is you can have all these systems in place ready to hit go, but if you don't have the work, you're not going to have and hold and pay for a workforce that's just waiting to do work, right? Like you have to hire all those eligibility workers to process those 90 million applications. And you don't want to have them just hanging out, not doing anything until it's time to process. So there's been a stop start. Are you ready? Wait, hold on. Get crouched. Nope, not yet. That sort of a back and forth for states. And it's financially costly. It is psychically, mentally exhausting. So that's part of the challenge. They've done all they can do to get ready for the end of the PHE, but they will have to have the temp workers or the other staff hired, trained, ready to go to do all the redeterminations. And that takes time. So anyway, sorry, long answer, but they've been doing so much to get ready.
No need to be sorry. I'm glad you mentioned the stop start, which I feel like has just been happening throughout the public health emergency. And there have been more questions from the audience about that kind of long anticipated preparation. So thank you, Diane. And Hemi, if you have anything to add, please go ahead.
I think Diane covered it really well. The only thing I would say that isn't specific to sort of Medicaid eligibility with the PHE is the flexibility for out-of-state health professionals and really the interstate compacts and all of that. I felt like it was all on like fast forward, right? Like we did like within 18 months, 7 years of work that, would have taken that much longer. I think the question is like, what happens now? And I think some states are being proactive and saying, oh, we're going to legislate to make sure we can still have these flexibilities. And other states are really not acting. So I really think it's going to be a patchwork once the public health emergency is over of how, they're going to really deal with sort of the workforce piece of it. And the other thing I'll just say, just to comment on Diane's point about the stop and start, totally agree. And the other thing is, neither the people who are currently on Medicaid nor a lot of the eligibility workers have ever been through redetermination. So it's like, let's see what happens when this actually hits, right? The people don't know that, like, oh, I've been on this program for like 2 years. Like, what do I have to do? And then there's eligibility workers. It's like, I actually haven't been through this process before. It is all new. And you just know, for anyone starting like afresh, there's, despite all best intentions, there's going to be challenges. So that's, I think, when we work at the state-based marketplaces, I think they're trying to step in those states because they have so much experience enrolling people, of like, how can we help? Like, how can we make sure people understand they can, if they're not eligible for Medicaid, there's the marketplace. I don't know how smoothly that's going to go in the FFM states, because the federal marketplace is just, it's not organized to have that, focus on individuals in a particular state. It's a national system. So I think there'll be some gaps there as well.
That is so helpful. And that point that you made about not just the individuals enrolled in Medicaid, but eligibility workers perhaps never doing redetermination had never occurred to me, and it's kind of frightening. So thanks for raising that as well. I think you both have been touching on this. We know the pandemic has been a driving force for health policy. And, Hemi, you just mentioned how we've maybe done 7 years of work in 18 months. I wonder if you both could comment about some of the recent policy priorities, both directly related to COVID and indirectly. You've been already touching on kind of the current issues, including telehealth, including some of the, no redetermination and, Medicaid. Anything else that you want to touch on that's really been driven by the pandemic?
I feel like I don't want to repeat myself, because there's some things, I think there's, on the public health side, are we going to be ready for the next pandemic? How are we going to use all these federal dollars that are coming to states right now, billions of dollars? How do we then really build up the data infrastructure and interoperability between things like public health and Medicaid and the health system at large? These are all things I think that are prompted by COVID, but are going to go in different directions in different states. I think the other piece for me is thinking about how some of the systems that we've always relied on, like nursing homes and home and community-based services, should that look different given kind of what we've experienced during the pandemic? The nursing homes really struggled, and they're going to continue to struggle. So kind of what's the future of that, and where do we go next? I don't know, Diane, if there's others you want to.
I mean, the other one I would add is the perennial issue of high cost drugs and kind of curative therapies, and figuring out a way that the financial burden is not, doesn't decimate the Medicaid budget, and force really, really tough decisions and choices. But everything else, I mean, I was going through my list, everything else was so laid bare or exacerbated by COVID. It seems to me, and maybe I'm just so kind of myopic and still in that pandemic tunnel, but it's just, it touches absolutely, it touched everything. Maybe it was just Medicaid. This population was hit hard, low income, high proportion of members from communities of color. Anyway.
Thank you both. I think, as you're alluding to, it's kind of almost like a redundant question, because that's of course driving so much of what we're thinking about in policy. I want to shift gears a little bit now and ask us to think about a little forecasting. You both are at the cutting edge of what's happening in health policy. Wonder if you can share your top 10 list for health related policy topics you anticipate will be a focus in the next 2 years for state and federal policymakers. So what do you think will happen on Capitol Hill, in HHS and state capitals, state agencies? Would love to hear your thoughts for the coming years. And please, either one can go first.
Well, I can jump in because it might be shorter than Hemi's. I mean, it's and I don't want to speculate about certainly about HHS or Congress, but it's going to be all about for states unwinding for the next when it starts the redeterminations. That's going to be so massive, and unwinding behavioral health, that crisis for the whole population, but particularly for kids. There is just kids are there is no. We don't have the infrastructure in place to take care of kids that are in most extreme behavioral health conditions. Some are literally being housed in emergency rooms. That is massive issue. LTSS, the things Hemi again already elevated, high cost drugs, another one, workforce huge. And then interestingly, the expansion of Medicaid is starting to kind of come up again. I think when states that haven't expanded are realizing the financial detriment that they are at, particularly their rural hospitals, for not expanding, and that they're seeing more and more evidence from states that did expand that it is financially beneficial. The federal government is can be trusted, or can be counted on to fund the majority of the expansion. So those would be my things. Hemi, what would you add to that?
I really agree with all of that. I would just double down on prescription drug costs. And maybe that's just because I just spent 2 days in Denver talking about this with state leaders. And it really has, I felt like there was momentum with the Inflation Reduction Act, and at the federal level really talking about that. But now they've done that, and they're not going to do much on sort of drug pricing for a long time now, because they're going to sort of rely on kind of sort of CMS doing its job on Medicare. At the state level, there's just, not just on, what is state spending with respect to Medicaid or state employees, but consumers going to elected officials saying, I am paying too much for my healthcare. I elected you, go do something. So governors and legislators, I think, have increased pressure with inflation being as high as it is to really do something on affordability. So I think there's going to be a lot of work on prescription drug and trying to understand health system costs. It's harder to know what to do on that side. We're spending a lot of time with our hospital cost tool, just trying to educate and give people data to then decide how they want to approach it. But sort of both of those areas, I think, are sort of ripe for kind of what comes next. I would also say, just on the social determinants of health, I think there's this recognition of we need to do more. And on the legislative side, like, what is that? Do we do more on housing? Like these programs already get money. So like, why isn't it working? And why aren't people better? And with the money drying up from sort of the pandemic response, there's going to be holes. There's going to be holes in programs and support for the public. And I think that over the next 2 years, there's going to have to be kind of a reckoning of what are we really going to do in terms of investments at the state level. And I'd say that's true. The federal level, this administration, they're focusing on social determinants of health, equity, behavioral health, all the things that Dianne already talked about. So that's going to also be sort of a drumbeat coming from the federal level as well.
Thank you both. I wanted to expand on something that you just mentioned, Hemi, but to get both of your perspectives. You talked about how sometimes when there's a policy set, at the federal level, it encourages that to happen at the state level as well. And sometimes when we've done something on a topic, you were mentioning drug costs, for example, it's kind of like, well, we've done it and there may not be as much momentum to go on. The specific example you gave was of the Inflation Reduction Act, thinking about, helping kind of counteract some of the drug costs in Medicare through a variety of mechanisms, including allowing Medicare to negotiate for drug prices, among others. I wonder if you both could speak to that tension, and how do you, as leaders in state and federal policy, help manage that when there are these big topics you brought up that are important, not just this week or this month, but over a long time. You just ended with social determinants of health. Maybe I think for our members, it would be helpful for them to understand how those momentum can build or not, and how you try to help impact policy.
Dianne, do you want to go first, or you want me to go?
Sure. Why don't you go first?
Okay. I'll just focus on the Inflation Reduction Act as just one example, because we've been doing so many years of drug cost work here at NASHP, and we're trying to take it as an opportunity for states. CMS is going to spend all this time and really, I think, change the conversation around how you negotiate for drug prices at a national level. Some states have tried to do it individually, and other states have said, we can never do what Massachusetts and New York are doing on an individual basis to negotiate drug costs. We don't have the capacity to do it in our Medicaid program. So I think, assuming we want CMS to be successful, assuming they're successful, is really taking what they do. And like, we just have a new model of like, you can reference to whatever Medicare negotiates in your state for the drugs that are sold in your state. And that's a way of continuing momentum. If your state doesn't have enough, or capability to create a prescription drug affordability board, or to get, some of these sort of broader measures passed with international drug referencing bills, this is something that's going to be a national standard and you can reference to it. So that's an example of like the feds really doing something pretty significant and the states being able to figure out how do they build off of it. I think on the flip side, and Diane, you could expand on this. So CMS, like, we're approving these new demonstrations with health-related social needs and new flexibilities to figure out how to cover supportive housing and nutrition and some of these other pieces that are somewhat new to sort of the Medicaid space. I think there's like a lot of our states are saying, oh, well, we want to do that too. If they got approval, maybe we should think about it. We already have a proposal and we're going to expand on it. We want to get XYZ. I think there's an emerging issue on getting broader Medicaid coverage for the incarcerated population. And Diane, you can correct me. I think it's like 13 states now that are requesting that, and CMS has not opined. So that's an example where CMS can set a whole new path on that if they decide to move forward. You probably have more to say on this though.
Yeah, no, I think I would pull up a little bit, and it's part of a larger just reality of our world, and that is that there's a very clear political tension when the administration is, when one party is leading in the administration versus another, and it is hard for state Medicaid programs to have to shift either their mindset or policy or requirements or something every 4 years, depending on who is in the White House and who's leading the administration. Let me just underscore that there are, our federal partners in CMS are incredible professionals. They are wonderful partners. They are supportive. They are steady. There are strong established relationships and partnerships that state Medicaid directors have with their CMS counterparts. But it is still, the political winds shift, and that can be hard to navigate and deal with. But Medicaid directors are nothing if not pragmatic. They just want to operate their program and get it done and provide coverage and access and healthcare to the people they're responsible for. So, but it's fascinating, particularly here in DC, just to, we're all kind of political animals or nuts, I don't know what, but to see those winds shift and to watch the states have to kind of respond to it.
Thank you both so much. And Diane, I suspect that many states view NAMD as a smoothing out force in some of those, political winds going back and forth. We're going to shift gears a little bit, and I wonder if we can start with your perspective, Diane. So, thinking about how, people such as researchers or experts at our university can engage in policy. I wonder, how do you or your members engage in partnerships or resource, with specific experts or resources outside of state government, university researchers being one example. And if so, could you give us an example or two, what things worked well, what didn't work well, just to help educate us?
Yeah, sure. So there certainly are external partnerships that are incredibly important to states and Medicaid agencies, particularly with universities in a couple different capacities, helping states to with data collection, performance measures, understanding quality of care. There are some arrangements where it is helpful to have university funding to support a position within that the state government could just doesn't have the pay scale or so. That kind of that clinical expertise can also be incredible. Medical expertise can also be super helpful. So I guess I would elevate those as a couple of ways. Medicaid agencies they're not researchers. They run an insurance program, and they can collect data and they can analyze it, but typically do not have that level of expertise within the Medicaid agency. And so that is deeply, deeply valuable and important to be able to connect with, because that's how you know, are we paying for what we should be paying for? Is our program working? Is it effective? So those are some thoughts.
Thank you. And Hemi, if you have additional thoughts, please add as well.
Yeah, I'll just sort of make focus on two examples outside of Medicaid, just for the broader sort of state work. So workforce is an area where I think is ripe. I'm just going to say it again for academic partnerships. I've seen examples in Indiana and North Carolina where partnering with their universities has really just opened the door to just such a broader sense of analytics and ability to predict and understand what the shortages are, that the state couldn't do that on their own. On the affordability side, I would say the same thing. I think states that are wanting to, do these really sort of expansive cost growth benchmarks or understanding like what are new economic models for us to think about, they don't have the capacity in-house, nor can they really hire that kind of capacity in-house. And so those types of academic partnerships have been incredibly helpful for those states. And I would say just personally at NASHP, we wanted to put out a hospital cost tool, which, we have an accountant on staff, but some of the other pieces of data collection, we had to go with Rice University to really understand what we could do. So I just think there's so many different areas where partnership can really lead to sort of better outcomes.
Thank you both for highlighting those examples. Of course, that makes me feel encouraged as someone, who enjoys working with our state Medicaid agency and other stakeholders. And just to build on this theme a little bit more, I wonder if you both could help us think about future priorities. Are there any areas particularly pressing that need evaluation, research, data analysis, innovation that university researchers could be helpful with?
You want me to start? Okay, there's a long list, but I'm gonna keep top three just for purposes of this conversation. Race and ethnicity data. We need to, all the states are working on it in different ways at different paces and frankly effectiveness, but really understanding race and ethnicity data among populations like children with special health care needs, the aging, just really understanding how do we want to drive policy. So that's one area. Another area is that health economic theories on bending the cost curve. We are trying all sorts of things and putting out all these sorts of models, and really more work on understanding where we really can make a difference, I think is really needed. So that's my second area. And then my third area is how can we really support public health? Like is there a way to show with data the impact of public health investments and how we can build a case for really sort of moving in a new direction in the future? Because I feel like that conversation is getting lost in terms of here's like examples of where investments were made and here are the good outcomes, as opposed to like, well, you required masking and vaccines and shut us down, so that was a terrible outcome. So really thinking about using data to talk about the future of public health would be incredibly important.
And I would just add a couple. We're very interested in doing a kind of a postmortem on what happened during the pandemic in Medicaid, what decisions were made, why were they made, what were the long-term effects of those decisions, would we do it again? If not, what should we consider moving forward? So that's a big chunk. And then the other thing, and that is, any like guidance, thoughts, on what the heck do you do with data from the last 3 years. So when states are trying to assess quality or cost or effectiveness of different programs, that the data are just bananas. They are, they just, so what do states, how do Medicaid agencies do that? And I think that's the same question for our partners at CMS, because they'll be asking similar questions about, well, what do the states do? How did Medicaid agencies do? And the data they have are going to be, also, because it's similar data, it's just going to be nutso. So what do we do with that? I don't know.
That's such an important point. I think we're all struggling with. So I'm glad you raised it, Diane, because what do we do with data from 2020 and forward is such an important question. But you're right. I think we need to put more thought into that. I know we're just getting to our last few minutes here. So I was hoping maybe for a brief minute to focus on one question for you to both reflect. And then we're going to have one closing question. So what are you most proud of that your organization has been involved in or impacted on the state or federal level? And I'd love to start with you, Diane, as you're stepping back from your interim executive director role back to deputy soon. That's a nice time to reflect.
Yeah, so I think there are a couple of things, and they are very much related, and that is, I think we have done a very good job of keeping the ship steady regardless of the political winds. We have worked successfully with all different administrations, different political parties, and I think we've kept our association intact. There are 56 Medicaid directors, and they are all part of our association. And so I think we feel proud of that, and feel that they feel their interests are best served by all being together. So I think those are probably the two biggies. I know that that's a pretty high level thing, but those are probably the most important.
Those are huge. Thank you. Go ahead, Amy.
Yeah, and I would share just, there's a lot of sort of policy projects that we're very proud of, but just at a sort of more macro level, that we're able to really work in a nonpartisan way with like blue, purple, and red states. I really think there's very few organizations that can do that effectively. And, behind closed doors, really have honest conversations about, here's what we're struggling with in our state politically, but what are some ideas that can get us to XYZ? Because actually at the end of the day, we have similar goals. And I'm really proud to be part of an organization that can work with states in that way, because I feel like that is incredibly powerful to really bring different ideas from different places, regardless of the politics. And, how you talk about externally is different, but how you can then work on it and move forward is so important.
Thank you both for touching on the steadiness despite COVID and political winds of your organizations. And I know we just have 1 minute left. And I know Sarah highlighted that for some of our members, we'll be having breakout rooms for those interested in discussing, but what are your closing thoughts for those of us here? What advice would you have for health services researchers, students, trainees, who want to engage and share important policy research to improve public health and population health? How can we be effective?
I guess I would be quick. I would say, first, Medicaid is an incredible place to focus in the policy sphere. So well done on you for being interested in Medicaid. And I would say simply, go work for a state. Go dive in, be there, get engaged, understand what it's like, and it doesn't have to be for forever. But go work within a state agency and use your skills and expertise there.
Excellent recruiting, Diane. So I would just add, help us identify at the state level, how do we do better coming out of this pandemic? And there's a number of areas that I talked about. What did we learn? Help us use the data to explain the story so that when when we're trying to help state policymakers say, this is what you need to do with public health, here's the future of nursing homes, here's how you can address disparities, there's data to support that, and really sort of explain with a story of how we can really do better with all the funding. Because my fear is there's going to be all this funding that's out there, and like 2 years from now, we're going to be in oversight hearings and everyone's going to yell about how the states did a terrible job. And I don't think they're, ultimately 100% to blame. So, help us paint that picture so we can be proactive.
Thank you both so much. I think you speak to the strength of the states, as leaders, and I really appreciate both of you as leaders taking the time to educate all of us today. It's really just been a phenomenal discussion. I know I learned a lot, and I'm sure the audience did as well. So I just wanted to thank you very much and start a round of applause. And you may see some virtual applause happening in the background, but thank you so much, Dianne and Hemi, for all your time today.
Thank you. It's been fun.
So,